Yeah, so good night, every person. I will show up you in the coming few minutes some interesting points about what Dr. Ali Zidane spoke about. But I like trials and I like evidence-based medicine, so I will speak fast, trying to clarify things to you, and also let me to speak sometimes in Arabic because we have some technicians and some nurses that could reach them easily. So the primary PCI is the gold standard of care. So should every patient receive this type of treatment. And we can appreciate here what happens when the patient develops myocardial infarction. There is a rupture plaque within a coronary artery that occludes the artery, and the catastrophic event will start to occur. If we introduce the primary PCI is the modern treatment of acute myocardial infarction in order to reopen the vessel. And rapid reperfusion to establish the coronary blood flow is very important objective in the treatment of such patients in order to save the myocardium. This should be done in an early and sustained fashion, and this eventually lead to myocardial salvage and survival. And the benefit of reperfusion is very important, especially within the first 2 hours. So the first 2 hours are crucial in managing patients with STEMI. So we have to all agree about that primary PCI is the gold standard of treatment with myocardial infarction, and should be, of course, done in a timely fashion, which is the reason why we started late, because we prefer to salvage the patient, better to come at 9:30 and to start the meeting. So the patient, of course, is more important than our meeting. But this needs a very skillful team and 24/7 service of cardiac catheterization, which is available in our hospital. So our hospital offers a 24/7 service for coronary care units and for cases of acute myocardial infarction. And we have to restore what is called TIMI-3 flow, which is the normal flow after we aspirate the thrombus and putting the stent and reopen the artery. So there is a superiority of primary PCI over thrombolysis or streptokinase in the past, which is demonstrated in many trials. Here, a very good point to start. There is some myth in treating acute STEMI. myth يا جماعة معناها أكاذيب، في شوية أكاذيب الناس بتتداولها، حاجات مش حقيقية عن البرايمري PCI، زي إن هم يقولوا إن البرايمري PCI is no better than thrombolysis. في ناس بيقولوا كده ودكاترة. Primary PCI is better but not much better. يعني زيها زي lytic therapy. Thrombolysis just needs to be given early. ده أنا بسمعه من دكاترة يقول لك لو العيان جه بدري هديله. Thrombolysis followed by PCI is just as good. Facilitated PCI إن أنا أدي العيان thrombolytic therapy وبعد كده أبعته يعمل قسطرة is the preferred option. كل الكلام ده غلط. Primary PCI is too difficult. This is not right. Primary PCI is too expensive. This is also wrong, and I will explain for you by the trials and by evidence-based medicine. There is a trial which is the PAMI trial. This PAMI trial showed comparison between patients who received lytic therapy, thrombolysis, streptokinase versus who received primary PCI. And there is great significant reduction in death, reinfarction, death alone, reinfarction alone, and hemorrhagic stroke in the arm in patients receiving primary PCI. The patient receiving thrombolytic therapy has more complications, more hemorrhagic stroke, more reinfarction, and more death. Not the PAMI only, there is also 23 randomized controlled trials that shows that primary PCI is superior or better than the lysis or thrombolysis in death, reinfarction, hemorrhagic stroke, and total stroke. Here in Sweden, the Swedish trial, the Rikshaia trial shows that death at 30 days وat 1 year ورeinfarction كلهم بيفيفر او بيشجعوا ان العيانين يعملوا برايمري بي سي اي. اللي بيعمل برايمري بي سي اي عنده مورتاليتي اقل في 30 يوم وفي سنه وانه يجيله ري انفاركشن تاني. النارمي 3 4 البرايمري بي سي اي دور تو بالون تايم. يعني ايه دور تو بالون؟ يعني العيان جه المستشفى فيرست ميديكال كونتاكت لحد ما البالونه هتخش توسع الارتري. كل ما الوقت ده قل كل ما المورتاليتي قلت. يعني ايه؟ لو البيشنت presented within the first 90 minutes المورتاليتي بتبقى 3%. لو ال 90 minutes دول بقوا 150 دقيقه المورتاليتي او معدل الوفاه عدى الى 7%. تتصوروا ان واحد لو قعد في المستشفى وعمل الساعه 1 هيبقى المورتاليتي ريت بتاعته 3%، لو عمل الساعه 2 هيبقى المورتاليتي ريت بتاعته متضاعفه مره ونص كمان. فالموضوع يا جماعه محتاج تايم. Time is very important in managing these patients. كلام طبعا للدكاتره اللي في الاي ار وطبعا زمايلنا اللي في الحسابات. So invasive management in STEMI. لما تيجي تعالج عيان بالبرايمري بي سي اي it's more effective. Revascularization is complete. تقدر تعمل hemodynamic وclinical support. تقلل الريسك اوف complications والريسك اوف stroke. ازاي نحسن التايم تو ريبرفيوجن؟ ازاي نعمل ده؟ فيرست عندنا حاجات قبل ما العيان يجي الهوسبيتال بري هوسبيتال. early patient recognition لازم نوعي الناس، لازم نعمل كامبين ان احنا نفهم الناس باعراض امراض القلب ويجيبوا بسرعه. early EMS activation, emergency medical service activation, which is actually running in our hospital. So the patient come to the hospital and within few minutes the whole staff will be arranged to be at his ease in the cath lab. We have a triage in the ER and we have a pre-hospital cath lab activation by phone. And after arrival to the hospital, we have a rapid ECG and assessment, and we usually make the patient go from the ER directly to the cath lab with a dedicated team of marvelous nurses and doctors and committed cath labs 24/7. The point of aspiration thrombectomy, we advertise about this, about the aspiration thrombectomy. Aspiration thrombectomy is very important because it makes the thrombus to go out, so everything will be nice. You have to restore the flow, get the thrombus out, then play in the artery as you need. Here, a very nice picture. You can see the thrombus, it's within the artery and the thrombus aspirated, and my assisting nurse, she was happy by that, and she captured it by her phone, and she gave me to us in order to show you how the thrombus could occlude the artery. Those who are in the high line, those who received conventional PCI, and those on the dotted line who received thrombus aspiration. So when we use thrombus aspiration, we have lower mortality, lower complications, and lower hospital stay. This makes the American College of Cardiology makes it a class 2A recommendation. So every patient with ST elevation primary PCI should receive aspiration. Aspiration is very important, and we learn people to use aspiration catheters. We advertise about that. Patients now came to me and asked, would you please aspirate the thrombus from my heart? And this is real. The aspiration will make the patient infarction size lesser. The left ventricular function will be more efficient. As regards the stents, the question by Dr. Ahmed Dawish, the stents. The stents, we have two stents, the drug-eluting stents and the bare metal stents, and this is a follow-up of 5 years comparing between the two types of stents, showing the meta-analysis that the drug-eluting stents has a great lower incidence of target vessel revascularization. يعني ايه؟ يعني العيان اللي بيركب drug-eluting stent بيحتاج اقل بكتير انه يعمل قسطره تاني ويركب دعامه تاني. غير اللي بيعمل بير ميتال ستنت بيبقى عنده فرصه ان يحصل فيها ريستينوزس تاني. So drug-eluting stents بتعمل 56% reduction في relative risk of target vessel revascularization، ان الفيسل ده يقفل ويحتاج يعمل دعامه تانيه. طيب العيان جاي اعمل له ايه؟ اروح الطريق ده ولا اروح الطريق ده؟ اروح طريق الثرومبولايسيس ستريبتوكاينيز ولا طريق البرايمري بي سي اي؟ البرايمري بي سي اي محتاجه شروط عشان تتعمل. اول حاجه وأهم حاجة الوقت. So the time is very important. First, we have to do it if the patient came to you within the, and you can do it for him within the first 90 minutes. This is the best time for him. And in Europe, they prefer 60 minutes. In USA, they use 90 minutes. Anyway, in 1.5 hours, you have to revascularize him by primary PCI. And this is very important. And if you are in a hospital which has no facility for PCI, you have to transfer him to another hospital, but the transfer should not exceed 2 hours. So the patient should be transferred from another hospital to our hospital, should not exceed 2 hours. And these slides show us that the 30 days, the reinfarction and stroke is much better to transfer the patient rather than to give him streptokinase in the hospital. So if you choose between the two, if you transfer the patient within 2 hours, it's much better than to give him streptokinase at site. What about the cost? Every person speaks that drug-eluting stents and the PCI is very costly procedure. But the right thing, it's a cost-effective. Here, there is a trial of cumulative cost of PCI versus streptokinase or thrombolytic therapy, and you can see that it's more or less similar, because in streptokinase patient here, it's in UK. This trial was conducted in United Kingdom, and they show that the total cost that the patient received thrombolysis will exceed the total cost if he received a stent. How? Because he will stay longer in the hospital, he will receive a lot of investigations, a lot of procedures, he may develop heart failure, he may develop arrhythmias, he may develop complications. All these procedures are costly, and the patient will pay in another way. So if you prefer to do primary PCI, it's more cost effective. As we heard from Dr. Ali Zidan, also PCI after thrombolysis is very reasonable. So in addition to the 50% of patients receive the streptokinase who will fail, another 20% will reinfarct. So we have 70% of patients that will receive thrombolysis and they will not benefit from thrombolysis, and primary PCI should be the solution. So after giving the patient thrombolysis, transfer to a PCI capable hospital is the rule in order to know the anatomy and to do revascularization to him. So what is the recommended reperfusion strategies if the patient with STEMI come within 12 hours of symptoms? A PCI capable facility، يعني جاء مستشفى زي عندنا مباراة العصافرة فيها PCI capable 24/7، he should go immediately for primary PCI. راح مستشفى سين أو صاد ما فيهاش قسطرة، هيقوموا شايفينه لو لقوا ان هو يقدروا ينقلوه مباراة العصافرة في اقل من ساعتين يبقى هينقلوه، ده الصح، العلم بيقول كده. لو هيتأخر هياخد ترومبوليتيك ثيرابي في حالة واحدة لو هو جاي في اول 30 دقيقة عشان يستفيد. وده ال 120 دقيقة دول هم اللي مهمين عشان يبقى البرايمري بي سي اي فايدتها تجب فايدة الثرومبولايسيس. البيشنتس بتوع كارديوجينيك شوك، تلاقي بيشنت قاعد في مستشفى في العناية كارديوجينيك شوك وعمالين يديله vasopressors. This is the patient who should be transferred to the primary PCI. This is a gold standard for this patient. He will benefit only from primary PCI. So for the ICU doctors, please don't let the patients to die in the ICU and refer them to us in order to recanalize their arteries. For delayed presentations, patients coming one day after the event with still chest pain, they still have some benefit in meta-analysis of the randomized trial. They have benefit of PCI versus conservative treatment. And late presentations is very important, especially if there is severe heart failure, electrical instability, arrhythmias, or persistent ischemic symptoms. As we said in cardiogenic shock, it's a must for the patient to be transferred for primary PCI. This is not my words. This is the words of the whole world. The American College of Cardiology and American Heart Association say that this is the guidelines. Should the patients receive this type of treatment. And this diagram showed by Dr. Ali also, that the patient, if candidate for reperfusion and he is in a PCI-capable hospital, he should go immediately to primary PCI. If the hospital is not capable, so either to transfer him less than 2 hours to another hospital, have PCI, or to give him lytic therapy within the first 30 minutes. Also the Europeans, not the Americans only, the Europeans, the ESC, the European Society of Cardiology recommend that. And they stress about the delays. The delays is very important يا جماعة. ما ينفعش نقعد العيان، ما ينفعش العيان يقعد في بيتهم يعالج نفسه بفوار وبعلاجات هوم تريتمنت. لازم نوعي الناس انه يتحرك دايما على طول للمستشفى لما يبقى فيه تشست بين. اول ما يجي المستشفى فيرست ميديكال كونتاكت يتشخص في 10 دقائق لحد ما يوصل لأوضة القسطرة ويتعمل له توسيع في أقل من 90 دقيقة. ده الستيت اوف ذا ارت ان كل العيانين لازم ياخدوه. وده نفس الدياجرام باليوروبيانز زي الامريكانز بيقولوا نفس الكلام، واحنا كلنا لازم نبقى فخورين ان احنا في مستشفى بارة العصافرة بنعمل كده بالظبط. النهارده لما جه العيان وقررنا ان احنا عندنا ميتنج عزيز علينا كلنا، قررنا انه يتاخر مش مشكله عشان نسيف البيشنت ونمشي زي ما الجايد لاينز بتقول. So conclusions بتقول ان البرايمري PCI when immediately available offers superior and safer reperfusion. It's effective dependent on the time. Elderly patients complicated are of a special benefit from these procedures. Skilled centers and operators that minimize PCI related delays enhance benefits. For us, the mortality rate in our department does not exceed 1% of the cases, which is very good number, which is ranked in the higher numbers of the well-known centers. I will show you in this movie few slides about a clinical case to describe what I said to you in a patient with extensive ST elevation, anterolateral myocardial infarction. He is a 55 years old man with crushing chest pain. He came to the hospital, to the ER, seen by Dr. Walid Debsi and his colleagues. The pains started 78 minutes, the baseline ECG, then he transferred to the cath lab immediately. You can see here, very obvious. You see here, the artery is occluded here. This is the LAD, the left anterior descending artery. It's a major artery. It's occluded here. The right coronary artery and circumflex are normal. Then we started to pass the wire, and this is the aspiration catheter. You see it dives within the artery. It dives and aspirate the bad blood full of clots and go out. Then we see the artery is started to regain the flow. Everything is okay. We have ulcer here. We will cover it by a stent. This stent was a drug-eluting stent. Put the stent inflated. The stent is inflated and make sealing of the vessel of the ulcer within the artery. Then we will see the artery totally opened, and this happens actually in 15 minutes. I can swear this occurs in the most famous hospitals in Europe and USA, and this is the final result with TIMI-3 flow, and the patient relieved from his pains, doesn't suffer any complications, and he was at home with his family next day. Thanks God for these great things. شكرا جزيلا.